So, amongst other things, this is what we're treating today. This is a lateral thigh perforating vein on the subject. Since Jonathan Earnshaw was talking about perforators and the fact you don't need to treat them, I thought we'd treat this one because this is the source of the trouble. Yep. And those veins go all the way down here, and these are the ones that you really don't like, aren't they? Those are the ones that we have to get got.
Which ones?
The ones on the outside.
Ideally.
Well, they will be, yes. Your every wish. And then they wander off over here and disappear somewhere. They go off all the way around there. So what I'm planning to do is to inject up here, and then hopefully with a cannula, I should be able to get a cannula in that. It's not the straightest vein in the world, but it should be okay to put a small cannula in. And then probably it would be possible to put a cannula in down here, but I think I might just directly inject foam into it, probably. If I can see a straightish bit, I'll put a cannula in down there. So that's one bit that we're planning to treat. And then if you look around towards me, what we also thought is that there is a problem with the saphenous vein at the front. If you lift this up a fraction, and just bend this knee and turn it out a bit. Just be careful of that. Couch is very feeble. There is some venous reflux in the great saphenous vein, or there was last time I looked at it. And so my plan is to treat this as well. Oh, it disappeared under your trolley. Well, there is not a lot of venous reflux in it at the moment, but last time we looked at it, there was some. And you've got thread veins in relation to it down here, which I expect you'll want me to disappear as well. Yeah, there are bits of this vein where there is some venous reflux, and my long and bitter experience is if we just ignore that, in somebody who's got varicose veins, there's some more varicose veins down here. So if we ignore that, we will be regretting it later. So I'm planning to treat this side of the leg as well. There are the varicose veins I'm complaining about. But you can see, and they join onto the saphenous vein. So there's the tibia just on the right of the picture. And that's the saphenous trunk, not a very big saphenous trunk, but the varicose veins join onto it. So I'm planning to inject the saphenous vein and perhaps the varices as well. So what I plan to do is inject local anaesthetic here, here, here and here approximately, and here. And we'll pop a little intravenous cannula in those places and put some foam in. And that should fix it. So the aim of today's treatment is to fill every single varicose vein in your leg with sclerosant foam. So we instantly cure everything. I think we should begin. You okay? You clear what I'm trying to do? Right. Okay, if you can carefully climb on the bed without knocking it over.
On my
These,
back or side?
and lying, I think in the first instance, if you'd be kind enough to lie on your side and look away from me, it will hopefully give us the best picture of your leg. So bring this over here and this down here. And this up here. So what I'm planning to do is some injections, all right, over there. Oh, sorry. It's the slightly difficult way for me, but I think this is going to be working out okay.
Still so
visible on the TV if anyone can't see it.
Right. Let's do this. Thanks. I'll go green to start with there. See how easily I can see the vein that I'm shooting at. Just straighten this leg out a bit. That's all right, see that bit, perfect. Oh. Time for champagne already. Yes, sadly enough, it's only water. Okay. So what we will do, I think, is cannulate that vein just there. So we're going to do a little injection of local anaesthetic. So Kate has added a 1/4 ml of bicarb to this syringe of lidocaine to make it less stingy when it is injected. That's Dr. Klein's solution.
Okay.
And so you can see the tip of the needle there just getting friendly with the vein. So I just need to steer that into the middle of the vein. So I'm just gliding that up the inside of the vein. You okay there? Still there? Good. Please let me know if I'm doing anything you don't like, because although I don't mind you saying how I do mind you suffering in silence. It shouldn't be, there should be no pain or suffering in this treatment. Right, so now we've got, sorry. Mm-hmm. Kate's keeping me in order. Right, so now we have the cannula inside the vein. We can see that on the ultrasound image, and if I squirt some saline in there, we can see that the saline goes in the vein and not anywhere else. So now I want to come down here a little. So here we can see the saphenous trunk inside the saphenous compartment in the middle of the vein, and then there's an accessory vein up there, and then there's another accessory vein behind us. And my experience is that we actually have to inject all of those to get a satisfactory outcome. And I think what we do is put a cannula in just here, a little injection in here. So we put a 18 gauge cannula down here. So these are not particularly big veins, in fact, but they do seem to be joined up to the varicose veins in, near the shin there, so we definitely need to inject these. So now we have the cannula in the vein down here, hopefully. Yeah, so it's an 18 gauge, which is long enough to go in most people's veins. The in morbidly obese patients, I think I'm not very keen to treat varicose veins because of the increased risk of deep vein thrombosis. But even in relatively plump people, one of these things will go in. And I tend not to use longer cannulas than this. So again, we can squirt some saline in and check that we're in the vein. And then this is the region of the varices, and again, there is the main saphenous trunk. So that in the middle of the picture is the main saphenous trunk, and that goes off towards the shin. And then we have the superficial accessory vein, where the varicose veins are arising. So again, we need to treat both, and that's where the varicose veins join to the saphenous trunk at that point. And what I quite like to do, and then there's a little perforating vein, a paratibial perforator going down there somewhere. So what I'd like to do is, we're going to another little injection here, is put a cannula in somewhere near the junction of the tributary or varicose veins with the saphenous trunk, so that when we inject the saphenous trunk, the foam will go into the varices. The converse strategy doesn't work. That was really Professor Fegan's strategy. Inject the varices and the trunk remains intact and carries on and creates more varicose veins after a short while. So you always have to put the foam in the into the saphenous vein. So there's my cannula disappearing into the saphenous vein. But I haven't forgotten about the accessory veins, which we'll treat in a minute. Thanks. Let me give you this as well. And then we just come down towards the ankle. And when I first did foam sclerotherapy, we never used to inject the saphenous vein down here. Just going to do another injection. I'll have a blue one, please, Kate. But and just occasionally, the saphenous nerve arborizes around the vein here, and when we hit the vein, we hit the nerve as well. So I'll put a drop of local anesthetic in the vein wall at the same time. Unfortunately, this bit of saphenous vein commonly does give rise to further varicose veins, and so I always put a little bit of foam in down here these days. Make sure it sticks, because we've got to have a change of position in a minute. I think, Kate, we'll just inject a little bit of 0.5% STS foam into those little accessory veins, one here and one here. So I think a little bit of foam up here would be useful, and a little bit of foam into this accessory vein down here would be useful as well. These are actually the varicose veins that we're trying to get rid of. So this is 0.5% STS foam, pretty feeble foam, but the veins are very of modest size and rather superficial injection in here then. Oh. I'll go with one more, yeah. So here I am trying to put the needle in that vein there and then inject foam. We'll just gently drift a little bit of foam in here, because I think this is one of the things giving rise to the varicose veins, and it may or may not get filled when I inject the saphenous trunk. Okay, that's good. Then we'll have a little go at the varicose veins down here. So somewhere around here there'll be straight enough bits that I can inject somewhere around here, like there. So another injection here. How's your leg feeling? Is it all right? Good. So just put the tip of the needle in that vein. And that 30 gauge needle is 12 millimeters long, and quite a bit of that's in the vein, so that's a reasonably secure injection. You may get some aching as the foam goes in the sort of the saphenous veins proper, but usually it's only short-lived. Okay. Right. So far, so good. I think a change of position is called for the first. So the first thing I'd like you to do is line your back and look at the ceiling. And then what I'd like you to do is turn a little towards me and lie on your side, looking at me. Just be a little bit careful about these cannulas. Thank you. Perfect. All right. Are you? And if you leave this leg in here. Oh, wait a minute. If you bring this leg back a little bit, we should be able to rest that down without causing you too much discomfort. Is that okay? The cannula's a bit angular. The plastic bits tend to stick in the other leg. So that brings us to this. And I'm just going to see if I can put a 22 gauge, a pediatric cannula in there. Go with another one. Thank you. Thanks. Let's go blue. Thanks. So this is far from being the easiest vein to cannulate, but we'll give it a go. Little injection in here. And then after this case, we're going to do foam into, I think just put direct foam into the varices actually. So there's the vein disappearing off down to its perforator. So we're right at the beginning of the vein there. Just hang on 1 second. I left rather a lot of scanning jelly here. Thanks. Oh. You all right?
Yeah, thank you.
You're good. We're making progress. Yeah, just to demonstrate that actually did go into the vein. If I squirt the saline in there, we see it going, well, what we don't see is it going into the tissues, it is going into the lateral thigh perforator, and then we'll just do some direct injecting into the varices. Could do this by eye. The trouble is I do ultrasound guided sclerotherapy as a routine, yeah. 2 mils, 0.5% will be good, thanks. So the varicose veins you can just about see come down here and around here, and some go over here as well. So we'll do 2 or 3 injections in the back here. A little injection in here then. Okay, so there's the foam drifting along the vein. We can see it on the ultrasound image, but we can also see that the vein is becoming paler by the moment. So it looks better already. Okay, same again, yeah. Ooh. Same again. So we go just a little bit further up. Little injection in here. So that's looking promising. And you'll notice what I'm doing is injecting starting at the top and working down, and that is because foam tends to run up the leg if you inject it down here, so it would obscure my view of the vein further up. So if I'm doing this technique, which is very similar to the way in which the French phlebologists treat the veins. That's an interesting structure there. I'm just going to plant an injection in there, scratch there. So this is a longitudinally running superficial varicosity, effectively, which will benefit from some foam. So there's foam going into the varicosities there. And now most of those varicosities seem to have got some foam in, so most or all of them will be destroyed. So that's pretty good. So I'm pretty happy about that. Right, now we're going to foam the perforator and superficial trunk. So I think now we can do the holding up of the leg in the air. Kim, do you want to volunteer to hold the leg up? If you come and lie on your back now, Kim is going to pull your leg. Yeah, we normally use an unpaid assistant for this bit of the operation, the drip pole. But today we left the drip pole at home and Kim came to help. No, you're good, I think. You're not in the way of the camera. The drip pole is skinnier than you are. But so now I'm flushing with saline, and this is got a small amount of lidocaine with adrenaline in it. So there's a very small amount of adrenaline in here, which will provoke some spasm in the saphenous vein, as well as flushing out the blood. So as in fact, I think Mike hasn't given his presentation yet, but foam is very strongly inhibited on contact with blood, so the idea is we get as much blood out of the vein as possible by elevating the leg, going back to dear old George Fegan again, and flushing the vein with saline. Invented, I think, by Ken Myers in Melbourne, and the foam itself pushes the blood out of the way. So a little bit of foam drifting in here. Put a little bit in down here. Don't like putting too much in at the ankle. Most of it's supposed to go in the patient, not on the patient. Doesn't work so well applied topically. So that is 5 mils in there. We're going to, if you waggle this foot up and down like this. You didn't come here for a rest, I think. And you can relax. So this manoeuvre is intended to encourage the flow in the deep veins and discourage the development of deep vein thrombosis. I'll go for 3 next, please. This is some more 0.5% STS foam. I'm going to put that in the perforating vein laterally. And so now most veins will be filled with foam. So you can waggle your foot up and down again there. Thanks. And I'm going to put some 3% in here. We'll make this the last one actually, Kate, because we've already put quite a lot of foam in. So here is some 3% foam. Yeah, that's good. Well, if we look at the veins, so you can see little white dots where the veins were. Sorry? You okay? You good? So this white dot right in the middle of the screen is the saphenous trunk proper. And I'm just putting a little bit of foam in there. And so pretty well everything is already filled with foam, but it has to be effective foam. So I'm going to put a bit more foam in at the top of the saphenous vein. And now you can waggle your foot up and down again. And that is all there is to it. I've put in 15 mils of foam split in between these two cannulas and this cannula, and another, I think it was 8 mils of foam in the varices, so that's sort of more than 20 mils. So we're what I would regard as a generous amount of foam, but sufficient to achieve the desired effect of destroying the veins. Right, time to bandage the leg. The best bit. This will be your friend for the next week. My friends from the Whiteley Clinic would like it to be 3 weeks, but I said I'd let you off. I'm not sure. Nobody knows, actually, for sure. Professor Fegan wanted 6 weeks, but he was very mean to his patients. He also made them walk 3 miles a day as well, which doesn't have any proven scientific efficacy. Kim, if you just abduct the leg a bit. Yeah, you can straighten out the knee. The knee is good straight. Yeah, thanks.
One candidate there.
Yeah, we do need gauze. Kate, could I have some gauze, please? The cannula is in the most difficult possible places. Well, this thing, as you know, this stuff has got a pretty hard end point, but I don't actually put it on at full stretch, unless I want the patient's leg to drop off. So it is fairly, it hasn't got much elasticity. No. So there it is, slack, and when I pull it, that's about as much stretch as you get. So. It is fairly close to its elastic limit, I would say. But the problem is if we put it on any tighter than this, the foot swells up like a balloon, or the patient complains of pain in the leg because we've shut the blood supply off to something important. So I find that this is about as tight as I dare put it. But I'm going to put a few layers on. That's a 20-metre bandage, and I normally put most of that on. Is that reasonably comfortable? You let me know. As you know, with these short stretch bandages, the pressure will go up a lot when the patient stands up, so it should work out okay. In fact. Thanks. So that's a bit of Medipore to stick the bandage to the leg. And we're going to stick more of this to the leg up here. How's your leg feeling? Is it okay?
It's quite achy here.
Achy is good. That's the vein feeling sorry for it still. Fine. Encourage my patients to think of that as the feeling of healing, aching in the leg. But it only goes on for 10 minutes in general. It normally goes away. It usually stays away. Occasionally it comes back, and if it does, Nurofen is good if it's troublesome, or paracetamol. If you can take either of those things, it's fine. So I think I've treated all or most of your varicose veins in that leg.
Thank you.
A pleasure. Have you got a pair of gloves? No gloves in the trolley? No. I must have put them in the other trolley. Never mind. There are some... One second. Have I got any wires attached? No. Yes. Oop. So these gloves have got Venasan written on them, and so have the stocking, so presumably one is intended to help with the other. Colin was showing how easy it is to put the bandage on, the stocking on over the bandage this morning. Which size bandage is stocking is this?
Medium.
Medium. Okay. You decided.
We ascertained both last week.
Okay. Thank you. Just need to hold this up off the deck a little bit. And keep your leg out straight so that I can lean against it. This trolley, this couch isn't quite as robust as the one I normally use. There you go. So there's quite a lot of friction between the stocking and the bandage, which should prevent it falling down too much.